everyone, and to say that we were very excited last year to be able to fund 5 different pilot research grants through the Sparkman Center to do research around health issues in low and middle income countries around the world. And so we're excited today to be able to learn about what's been going on with one of these projects. So, and I will turn it over to Dr. Halova to introduce our speaker.
Yeah, thank you, Dr. Turan. Dr. Turan is the director of the Sparkman Center for Global Health. I'm Anna Helova, and I'm the program director in the Sparkman Center for Global Health, and I would like to welcome all of you today. I would also like to mention, to add to what Dr. Turan mentioned, if you are considering applying for the next cycle of pilot grant funding from our center, the funding opportunity will be open in December. We will also host a workshop that can help you to prepare a good, successful application for this opportunity. So please save your date on your calendar. This workshop will be hosted online on November 11th. And with that, I would like to introduce today's speaker and awardee of the 2019 Sparkman Pilot Project. Dr. Tipre is a Sparkman Center scholar. She's also a scientist in the Division of Preventive Medicine in the UAB School of Medicine, Office of Community Outreach and Engagement, and also a scientist in the UAB Comprehensive Cancer Center. Her research focuses on fly ash exposure, and she will go into a little bit more details about what actually is fly ash. She also focuses on indoor and outdoor air pollution and environmental health. Dr. Tipre is also a trained dental surgeon and has been part of several NASA developed programs focused on spatial analysis related to tornado genesis, West Nile virus, and Lyme's diseases. With that, please help me welcome Dr. Tipre.
Thank you so much, Anna. Good morning, everyone. So thanks for the introduction. So my name is Meghan Tipre, and I'll be talking about my study in Sri Lanka on fly ash exposure and infant neurodevelopment. It's a pilot project, and this is our, so I'm hoping that everybody can see my slides. This is our research team in Sri Lanka. For this project, we collaborated with the University of Kelaniya in Sri Lanka, who have been our long-standing partner on several projects with my faculty member, Dr. Satya Kumar. We worked with them on R01s and R21s in the past in the area of air pollution. So also for this project, they were really key partners to make this happen. So from UAB, we have me and my faculty mentor, Dr. Satya Kumar, were on the team. And from Sri Lanka, we had Dr. Rajata Wickremesinghe and the rest of the team with 4 research assistants. What I'll be going over today is a bit of introduction and background, what this study is about, the specific aims, methods, some preliminary results because we just got the data in, challenges due to COVID and otherwise working in a developing country, and the possible impact of this project. So the story begins with fly ash, which comes from coal-powered power plants. So as some of you may know, coal supplies over 1/3 of global electricity worldwide. Almost 38 or 39% of electricity worldwide is supplied by coal-powered power plants. And majority of it is from the graph over here at the bottom. You can see that some of it majority of it is in Asia Pacific and Asia and Southeast Asia, and the use of coal, while in other countries, especially North America and Europe, it's slightly decreasing. It's still increasing. It's significantly increasing in China, India, and some of the other South Asian and Southeast countries. So what really happens in a coal power plant is when the coal is burnt in a boiler, the thermal energy is generated, and this whole system, when the coal burning happens, there is residue that remains back once the coal is burned, and it's in form of ash. Two types of ash products are created. They're called coal ash, which is really a byproduct particulate matter, which is then collected in ash disposal systems. So there are two parts to coal ash. One is the fly ash and one is the bottom ash. So fly ash in earlier times, in older power coal plants, the fly ash would be released in the atmosphere. But later on, due to air pollution control, this fly ash is now captured, I would say, with electromagnetic systems, and is collected in systems that is then either recovered or is disposed in landfills. So the coal ash, the whole residue is called coal ash, and fly ash is a component of coal ash. So depending on the type of coal, the composition of fly ash and the bottom ash changes. So as you can see here, fly ash is really fine particulate matter, and you would have the bottom ash, which is a much more larger particulate matter of the residue of coal ash. So the bottom ash is usually usually gets recycled, but the fly ash, only 40% of the fly ash is recycled. And when I say recycle, it is used in different, it can be recovered and used in construction sites, but almost 60% of fly ash is deposited in landfills, and it's open to the atmosphere. Fly ash is typically a fine gray to tan silt consisting of particulate matter with diameters less than 10 micrometer. It consists mainly of silica, aluminum, iron, calcium, and oxygen, and also may include trace heavy metals like mercury, arsenic, lead, and cadmium, as well as some small quantities of radioactive elements. It really depends on what kind of coal is used. So we have three types of coals. It's bituminous, subbituminous, and lignite. And depending on the type that is used, the constituents of fly ash changes. So given that these are the constituents, there have been some studies in the past that have looked at fly ash exposure and health effects, mainly fly ash as an air pollutant source because of the fine particulate matter, which is even less than, ranges from 0.5 micrometer to 300 micrometer. And they've looked at different health effects, such as cardiovascular health effects, respiratory, and also studies have looked at birth and early childhood outcomes. And in children, they've looked at low birth weight, infant mortality, and infant neurodevelopment impairment. And there have also been several studies on the heavy metals that are found in fly ash, such as mercury and lead and arsenic. And those have also been linked with from different other sources, not from fly ash, but other sources linked with infant neurodevelopment, adverse effects on infant neurodevelopment and birth outcomes, as well as arsenic has been linked with cancer. So while the levels of these heavy metals in fly ash might be much lower than what the occupational studies or the environmental studies have looked at, still they in some cases the levels could be higher in the environment over time, which can lead to adverse effects in the population that might be residing in the close vicinity of the fly ash landfill sites and the coal power plants. So that is why we wanted to look at what the fly ash exposure, look at the fly ash exposure and health effects in children. And particularly we wanted to focus on infant neurodevelopment because only 2 studies to date have really looked at infant neurodevelopment and its relationship with fly ash. One of the study was conducted in China in 2007, and it was a birth cohort study that looked at 133 children who they collected cord blood at birth and looked at prenatal exposure to ambient pHs, lead and mercury. That pHs is polyaromatic hydrocarbons, and from coal-powered power plants. And they looked at outcomes, decreased developmental factors such as language and motor development in children at 2 years of age. And another study was conducted in US by Dr. Christina Zerol. She's a professor here in School of Public Health. The study looked at 111 children between the ages of 4 and 17 years in vicinity of power plant. And in this study, they looked at proximity to living closer to the power plant versus further away, and found that a higher occurrence of attention deficit, hyperactivity, GI problems, gastrointestinal problems, and sleep disorders were observed in the children. This study has been further expanded to an R01 study that is currently ongoing. So our rationale to do this study in Sri Lanka was first that there are really few studies worldwide that have looked at exposure to fly ash and child neurodevelopment. And children are particularly at high risk, even at low dosage, right? So because of their small body size, hand-to-mouth activity, outdoor exposures, and immature metabolism. And none of these studies in the past have examined younger infants, and none have fingerprinted fly ash directly from the dump sites. And this is mostly because of legal issues that environmental scientists are not really able to go and collect. I'm sure that EPA may have some results, but they are not publicly available. So typically the previous studies, the way they measure exposure is measuring air pollution levels in homes of the children, or doing personal monitoring to look at air pollution exposure, but they were not able to actually find out what exactly the fly ash constituents were. So our research question from the background leading up to was to evaluate whether proximity to coal-powered plant in Sri Lanka and the coal ash disposal site may impact, whether it impacts infant neurodevelopment in children 1 to 3 years of age in Sri Lanka. There are 2 innovations I would say about our study. One is that we were able to fingerprint the fly ash from the concerned power plant, and this would be the first study published to do so. And then also, it is the first study in South Asia looking at fly ash exposure and infant neurodevelopment, and third study globally. To give you a little background about the power plant that we looked at, it is the first power plant in Sri Lanka. And in Sri Lanka in general, the electricity demand is currently met by 9 thermal powered stations and out of that, 22% is by coal, 53% is by 53% is by coal, 22% is by steam, and then the fuel is 30%. And then we have about hydroelectric power stations, and then 15 renewable energies like wind farms and other energies like solar. But as you can see here in this graph, the dark orange really represents thermal coal, and you can see that that is on the rise, is increasing. So the demand for coal-based, coal-powered electricity is increasing in Sri Lanka, and they've established the first power plant in 2011, but they plan to establish 2 more power plants in future. So our study, the power plant that we were looking at, it's called the Lakvijay Coal Power Plant. It's a 900 megawatt station. It's located in Kalapitia Peninsula in the northwestern province in Sri Lanka. It was commissioned in March 2011. It has 3 generators using coal, as you can see from these 3 stacks here. And it's located on a strip of land. And my next slide would really show you a couple of slides. I can show you exactly where it's located in reference to the area nearby. But here, if you can notice, all these are really villages. It's not simply trees and land, open land, but people are living here pretty close to the power plant on for the north and on the south side. These are some pictures about the Lakvijay fly ash dump site, and you can see this is what I was saying, that the fly ash landfills, they are just deposited near the power plants. Usually that is the case even in the US, and you can see from the wind, the fly ash flying in the air, and being so close to the coastal area, a lot of those winds sometimes come inwards and are spread to nearer villages that are located pretty close by to the power plant. And only 27% of fly ash in Sri Lanka is currently recycled. So the fly ash can be used to make in construction, making bricks or cement, and so far only 27% is used. Okay. So we were able to, prior to beginning of the study, we were actually able to fingerprint the fly ash. Samples were brought to US from the dump site, and the samples were sent to a lab in Kentucky. 2 methods were used to fingerprint the fly ash samples. The first one was the particle-induced X-ray emission. It's called PIXA technique, and it has sensitivity in the range of milligram per kilo weight, and it is able to so. Using that analysis, we were able to detect arsenic in our samples, which was 40 times higher compared to the EPA acceptable limits in soil near residential areas. The lab also used inductively coupled plasma mass spectrometry, which is ICP-MS, short for ICP-MS, and that is able to detect metals as low as 1 part in 10. And we found that we found some trace elements such as lead, chromium, mercury, and cadmium. So these are the levels that were detected in the fly ash. But this was not part of the study. This was done prior to the study started. So really it became more of a rationale for why we really wanted to look at the fly ash exposure and focus on infant neurodevelopment. The specific aims of the pilot project were to classify children aged 1 to 3 years into two categories as exposed and unexposed based on the proximity to the fly ash site, dump site. So because we did not have any other, we wanted to use proximity distance from the fly ash dump site as the exposure. Children who were residing less than 5 kilometers were defined as exposed, and children who were residing between 10 to 15 kilometers away from the LCPP were defined as unexposed. And the second aim was to evaluate the relationship between fly ash and infant neurodevelopment on different domains of infant neurodevelopment and behaviors, assessed by the CREDI scale and the Bailey scales for infant and toddler development, edition 3, adjusting for potential confounders. We also added a secondary outcome, that is respiratory health, illness, history of respiratory illness, to our second aim. Since we were collecting data, with these children, we added a brief questionnaire on respiratory illness as well. So this really, what I was saying earlier, where the location of our study site is. So if you can see the small green dot here, that is where the power plant is located, and it's a peninsula in the western province of Sri Lanka. This is, and Sri Lanka is an island country of about 21 million population. And this whole strip of island is the Kalpitiya division, and it comes in Puttalam district. In Sri Lanka, the health, the Ministry of Health has divided the entire country into administrative units, and the smallest administrative unit is called the public health midwife area. And in Kalpitiya, there are 19 public health midwives area, and we selected 8 out of 19 for our study. The total population in Kalpitiya is about 250,000 people, of which 11% are children under 4 years of age. So we had enough population in the vicinity of the power plant to conduct this study and have adequate recruitment in the study. The main occupation of the population in this area is fishing industry, especially shallow sea fishing and prawn farming. So before, I just wanted to give you an idea what really is a public health midwife area, because the PHM, which is a public health midwife, they were really vital to our recruitment and retention of participants in our study. So each PHM, that is a midwife, PHM is public health midwife. It's usually a woman who has completed 10 to 12 grade of education and is trained. You can think of them as lay health workers. Typically, this is also a common thing in other developing countries. So in Sri Lanka, PHM serves a population of about 3,000 to 5,000 people. And routinely, the PHM is tasked with conducting home visits to care for pregnant women, newborns, infants, and preschool children, and offer family planning services. So they from the time that a woman even is planning for pregnancy to the time that child is delivered, and then the child is closely followed till 5 years of age. So there is a roster that the PHM maintains for all the children below 5 years of age. And we were able to use this information to select our eligible sample for our study, and also take their help to approach the participants' household and enroll them in this study. The inclusion criteria were infant between 1 to 3 years of age, singleton birth, had to be a resident in the study area for at least 1 year, and mothers or caregivers were consented to participate in the study. And we excluded any children who were sick with a chronic condition that prevented them from participating in the study. This is our study recruitment area, specifically from all the 18 PHM areas. We selected 8. So the blue ones are the ones that are further away. The Lakvijay power plant is located somewhere here in the middle of these yellow outlined PHM areas, and the blue ones are the ones further away. So, and then children selected from these PHM areas were either grouped under exposed or unexposed. Our target sample size was 220, 110 from the exposed area group and 110 in the unexposed group. Data collection included for exposure assessment, we collected the GPS coordinates of the homes of the children and measured the distance from the power plant to the child's home. And then primary outcomes were child neurodevelopment. It was assessed by 2 scales. So the first one was caregiver reported early childhood development instrument. It has been tested in more than 17 countries. It's more of a screening tool than used more for screening studies rather than in clinical practice. But we also added to that Bailey scales of infant neurodevelopment, which is a standard tool used worldwide to assess a child's cognition and motor development from ages 0 to 5, 6. This one we focused on 0 to 3 years, 1 to 3 years, I'm sorry. And then the secondary outcome, we used the American Thoracic Society questionnaire. It's a 19 items questionnaire to ask about history of child respiratory illness. And it's a standard questionnaire, again, used commonly for studies, surveys, and we collected data on their last 6 months history of any respiratory illness in the last 6 months. So a little about the CREDI. It has 5 domains that it assesses for child development from birth to 3 years. That includes motor development, language, cognitive, socio-emotional development, and mental health. It has about 103 items for ages 1 to 2 years and 95 items. I don't know what happened here. 95 items for ages 2 to 3 years. It takes about 20 to 25 minutes. The Bailey scale assesses gross and fine motor component. It also assesses a language component, it's not included here, and the cognitive component. It takes about 1.5 to 2 hours. And the Bailey scale assessment requires trained research assistants who are able to conduct this in a clinical setting. So it cannot be just be done at home. We have used Bailey in the past in Sri Lanka, and the scale was validated by one of our co-investigators from Sri Lanka. It was translated in Sinhala language, which is the most common language in Sri Lanka, and validated and tested, and the paper has been published in 2013. Other information that we collected was demographic, wealth index, other risk factors like exposure to environmental tobacco smoke, pesticides, lead, indoor and outer air pollution. Child birth records and immunization records were obtained from the PHMs for their they maintain a child health record diary for all children, and we were able to retrieve that information from these records. And anthropometric measurements were taken for children, as well as a 24-hour recall for child nutrition. in mothers, we assessed maternal IQ, depression, and maternal obstetric history. Before starting the study, we received approval from UAB and University of Kelania's ethical review boards. All the instruments, the baseline questionnaires and other assessment tools were translated in Tamil and Sinhala, or had been translated earlier in previous studies, which we were able to use. Then before implementing the study, all the tools were pilot tested with 5 participants to test for readability, feasibility, and to establish standard operating procedures. And then the data collection began on February 10th of 2020. So while the study did get funded in June of 2019, we had some delays with the IRB approval, and there were some strikes going on in Sri Lanka, and so it was a bit delayed, and the study finally began on the data collection began on 10th of Feb. And we ended the data collection on 25th of September. So more about that a little later. So with what typically happened was that once we had identified the child who was eligible to participate in our study, with the help of PHM, the research assistant would visit the child's home, administer the informed consent, and enroll the child in the study. Then the research assistants would administer the baseline questionnaire and conduct the CREDI assessment. Then they would schedule another visit, a second visit, for the participants to come to the PHM clinic. And because the PHMs are locally, they are located closer to the residential homes, it's about like the PHM clinic would be 1 kilometer to half a kilometer from the child's home. So we arranged transport for the participants to be brought to the PHM area clinic for getting them assessed for Bailey 3. And that took about 2 hours. So we had a team of 4 research assistants who would, 2 of them would do the home assessment, and 2 of them the same, and the 2 others would do the Bailey assessment. So it went hand in hand, and that is why we were able to really complete our data collection halfway before COVID started and everything had to be shut down. So, and again, as I said, PHM, the public health midwife, was vital to all our aspects of our study. Because they accompanied us to the homes of to children's homes, and then we had to take special permissions with the medical officer of health under which the PHMs are to conduct the clinical assessments for Bailey in the PHM clinics. All the data was collected using tablets and open sourced software that is called Open Data Kit software, similar to REDCap. We were not able to use REDCap simply because it does not allow us to use Sinhala translation. So all the questionnaires were translated in Sri Lanka, and then this database was developed to collect the data. Incentives were given to all participants, which included 2 packets of milk, 2 kid storybooks, and a toy, mainly a bubble bottle that really engaged the child while the mother was participating in the baseline questionnaire. So that was, I think, brilliant on part of our research assistant to decide on the toy. And it amounted to about 500 Sri Lankan rupees, which is approximately $3 in US currency. This is a plan for analysis. We would be looking at the mean distribution of the scores, composite scores for CREDI and Bailey, 3 across our main exposures and other covariates in univariate analysis. And then we will use general linear models when looking at the scores, which are continuous variables, and exposures and covariates, and look at a secondary outcome, which is respiratory illness, again with the same approach. And then the 4th part would be comparing agreement between CREDI and Bailey 3 scores. So this is just a proposed plan. As I said, we started the collection in Feb 10th. Then we had to stop the data collection by March 30th and resume the data collection in August 15th. So because of that whole gap, we just received our data 2 weeks ago. We finished our data collection 2 weeks ago. So we've just looked at the data, and I have some preliminary results over here, but really the most of the analysis is yet to be done. So overall, we recruited about 221 children, 112 from less than 5 kilometer zone and 109 from more than 10 kilometer zone. The average age was 23 months with a standard deviation of 6.7 months. 59% were male children. And these are preliminary results for, that should have been a p-value over here, sorry about that. So as you can see here, the distribution of male and female children between exposed and unexposed groups are almost similar. There's also no difference in average age between the two groups. And here are some of the initial results for Bailey 3 mean and standard deviation for these scores. So these are the numbers. And as you can see, there's some imbalance in total numbers. It's because sometimes a child was not, they were not able to conduct the assessment in the child, or the child was not responsive. So some of that data would be missing for cognitive and motor. So as you can see here, in the exposed groups, the language, there is no really notable difference between the cognitive composite scores for between the exposed and unexposed. But in the language component, the exposed are low, children have a lower mean score compared to the unexposed score, unexposed children, and the p-value is less than 0.05. Similarly, for the motor scores, the composite scores, the average composite scores for exposed are lower as compared to the unexposed children. And the p-value is, again, less than 0.05. But this is just preliminary results. We have to review these results after adjusting for several confounding factors, and we're hoping to do that soon. So these are some of the strengths of the study. We were the first study to fingerprint the fly ash from a disposal site, fly ash disposal site. Then we were able to really leverage the well-established primary healthcare system in Sri Lanka, which led to more than 100% recruitment and retention despite COVID. And in Sri Lanka, because of their strong primary healthcare system, the maternal and child health indicators are really on par with some of those in US and Europe. So other confounding factors that are typically found in other low-income countries, those are taken, we don't need to take that into account. So we reduce some confounding by such other factors. We were able to use robust measures for outcome assessments, and use of GIS and proximity analysis is a low-cost method to assess environmental exposure, as well as minimal confounding by other industrial sources in the vicinity of the power plant. So typically, air pollution could be from other industries that is commonly seen in the US setting, where you would have the coal power plant, but you may have other industries as well. So this was not the case in our study setting. So the exposure mainly is, and it also is an area which does not have as high traffic. So air pollution from traffic would also be somewhat lower. Some limitations are, it is a cross-sectional study, so it has the limitation of a typical cross-sectional study, temporality, one point in time. And then we, of course, did not have, we were not able to do exposure assessment using environmental monitoring or any biomarkers or personal monitoring. So, And some of the challenges that we faced while conducting the study was mainly that it had to be stopped in midway on March 30th. And then additional costs were required to maintain the research staff because, as I mentioned earlier, to conduct Bailey and we had trained the research staff, and we wanted to make sure that they were the ones to complete the data collection and reduce any bias that might come from different data collectors. So that increased the cost of the study. And for the later part, which is about 58 participants, we were not able to do in-home measurements. So we had to get special permission to go to the area to complete our study procedures, but we were not allowed to go to the homes of the participants. So participants were asked to come to the PHM clinics where we administered the baseline questionnaire and also the Bailey. Because of that, we don't have GPS coordinates for those homes. But it is not a major limitation because we know exactly which PHM areas they are coming from, and would be able to approximately have a measure of distance from the power plant. The potential impact of this study is mainly that it will add to the body of knowledge and pave the way for future studies. And also it has implications for potential regulatory policy change in the way fly ash is managed and controlled in Sri Lanka. It also has definitely important significance to the results would have significance both in developing countries as well as developed countries, which continue to use coal as a source of which have coal power plants running in their countries. Our next steps is to complete manuscripts and expand the pilot project to a larger study. I would like to acknowledge, first of all, my mentor, Dr. Satya Kumar, who was instrumental in developing the study with me, and then Dr. Rajita Vikramasinghe, who has been our partner for more than 10 to 15 years and has given complete support to making this study possible, especially because it's a bit of a sensitive topic. So we have to go through different levels of the government, from the provincial health department to the local medical health officer and the PHM areas, and they made personal visits to help us implement the study. And our research team, especially Amandi Caldera, she is a program manager on the study, and she went above and beyond to make sure that all the study procedures were completed and on time. The local health department, PHMs, public health midwives, who helped us to collect the data, our research participants, and definitely a Sparkman Center for funding this research and making this possible. Thank you. I'm open for questions now.
Hi, Megan.
Yes.
Thank you for a nice presentation. I did have a couple questions and comments. The first is, I know you're going to attempt to publish these results. I would be very careful about using the term fly ash. What you have measured is actually particulate matter in terms of looking at what's coming out of the power plants. To measure fly ash, you would need some kind of indicator from an exposure assessment. Because what's put out by the power plant is a lot of stuff. What comes out of the landfill is a lot of stuff. And you're looking at a geospatial analysis, which is very valuable because you've done it in another country, which hasn't been done before. And you've looked at a younger age population, which hasn't been done. But I would just be careful to make it more something like power plant emissions, because you don't have the marker that they were actually exposed to fly ash. You have the fingerprint of the fly ash. How would that help you in your study or your next study?
Well, definitely. Thank you, Dr. Zaral, for those comments and questions. Well, as you rightly said, right now we just have the spatial exposure. We do not have any environmental, we were not able to do any environmental sampling or monitoring in the children. So that should be something that we should be cognizant of when writing the paper. And regarding the fly ash fingerprinting, for the future study, I think including some sort of environmental sampling when we write a bigger study, environmental sampling as well as personal monitoring would be critical to define the exposure in the population that is in vicinity to this power plant. So it sort of gives us a direction. The fly ash fingerprinting gives us a direction as to what we would need to measure if we do plan to do the personal monitoring.
Thank you. Good luck.
Thank you.
Hi, Megan. My name is Kaylin. I have a question.
Sure.
Yeah, so with the study, I know you mentioned that you were conducting the in-home approaches with the children. Are you all there to see just one child, or are you going to see like multiple kids? Like maybe if they have like brothers and sisters, are you going to conduct that on all of them or just one?
Well, for this study, we focus only on this child that met our inclusion criteria and only child in the household. We did not evaluate any other children in the households, but if we were to plan a future study, that may be something that we may want to consider. But as of now, we're focusing on the children that are in the study.
Okay, yes, ma'am. Thank you.
Dr. Tipre, we also have some questions in our chat, so let me start with some of them, if that is okay. We have a question, are there any risks related to fly ash in the United States in areas where coal is still being burned for energy?
Can you please repeat the question? I'm sorry.
Yeah, and it's in the chat as well. But basically the implication for the United States, are there any risks related to fly ash in the United States in areas where coal is still being burned for energy?
I think I do not want to say anything without actually giving actual evidence, but most of the studies I think have come from Dr. Zaral's studies in Kentucky, and I think North Carolina, they've done a lot of studies because there are coal power plants in that area. I am not so aware about the whether these power plants are located in areas, either are they low socioeconomic or minority populations, but that would be something that can be looked into. I do know that in the US, the distance between the power plants and the residential areas are much larger than what we observed in Sri Lanka. So Dr. Zaral can tell more about it, but it would be something, it's more than definitely 25 miles, so something away from the power plant. So they are further away, the residential areas.
And just as a reminder, so the distance that you measured and applied in Sri Lanka was 5 kilometers, so about 3 miles.
Yeah. We did less than 5 kilometers, and the unexposed was 10, but I would not even call them unexposed. Really, that would be a sort of a misnomer. I should say less exposed rather than unexposed, because as we have not done any personal monitoring, we really do not know what they are exposed to, what levels they are exposed to. So I would just say less exposed.
Thank you. Curious, there is another question. How were the cutoffs for exposed and not exposed or less exposed determined? Is there some evidence regarding how far the fly ash can travel in the air?
Some recent evidence does suggest that it can, for fly ash, it could be more than it could be more than 10 miles, which is really given our buffer zone. It was both the exposed and the less exposed were within that. But other environmental studies, they have typically, some of the literature that we reviewed for the study, we saw that normally environmental source, pollution source and the distance when you're using proximity analysis, less than 1 mile is considered exposed, and and further away, that is for us, we use 10 kilometers was, those were considered less exposed, but we did not come across very definitive cutoffs where we were able to define, okay, this at this level we would not see fly ash exposure. Other thing to consider was we wanted the demographics of children similar. Where the power plant is located, it is mostly fishing population, and also there are some ethnic differences between the mainland Sri Lanka and this population. So we wanted to keep both the groups as similar in demographics as possible.
Thank you. We just got another question from Dr. Irvin. How does the environment you study differ from or compared to North Birmingham Superfund site? Yeah, so the comparison of your site to North Birmingham.
Oh, North Birmingham. Okay. So
yes, Superfund site.
How does it, I would say, because, well, I showed a picture of the dump site where the fly ash has been deposited. And recently in 2018, the coal power plant expanded that area where where the coal and the fly ash disposal was expanded much closer to the village, local villages. So, and it's open. The fly ash disposal sites, it's open. It has almost a 16 feet wall. There's no barricades that prevents the fly ash dust from flying inland towards the villages. So I would say that. Whereas the North Birmingham site, the exposure, it has happened already, and for our side, it is continuing to happen. Well, who knows, and based on our study, it is possible that this could be something similar to a Superfund site in future. But I guess what I'm saying is that North Birmingham site, the exposure is both from air pollution and also from soil. So somewhat similar, we may find similar findings, but we have not done environmental sampling, so I cannot say whether the soil and the water has any evidence of pollution at this point. I'm hoping that I answered the question. I'm not sure if I understood the question as correctly.
Yes, you did. Thank you.
Okay. Any other? I'm going through the questions, Anna, and
I would also like to ask.
There's a question about mercury. There was Samantha Whitfield had a question about mercury content of whether it bioaccumulates in fish and other aquatic life.
Yes, I mean, definitely it would be something that we would have to look into, because particularly this population, the main staple diet does include higher quantity of fish. And in general, in Sri Lanka, people eat fish a lot. So that might be another consideration that we would have to see, whether there is leaching from the fly ash and the mercury in the water sources, which again, but most of the fishing, seafood, fish comes from the sea, so it's a seafood, so it would probably not be such a, from mercury exposure from seafood intake may not be such a big issue in this population. But we have to see. I cannot comment on it without actually supporting it with some sampling data.
Thank you. I would also like to ask, why did you decide to work in Sri Lanka? What makes that country ideal for this kind of study?
Several reasons. First major thing was that we have really strong collaborations in that country, and we've worked very well with them in the past. So we were assured of support. But the second most important thing, because of the topic of interest, and there was more of an interest from them that they wanted to look at this matter, fly ash exposure, because there were some concerns about health effects from the for people in this area, and they were interested in doing such a study, and it was almost timely that the funding opportunity came and we were able to put the study forth. And the third point I would make is the primary healthcare system in Sri Lanka. That allows us to really work well with a very well established system, with, especially if we are to do studies in maternal and child health. The record keeping is great, and we are able to do the studies at a much lower cost, and the other confounding factors are minimal because the maternal and child health indicators are on par in US. So such a study to do in US would be really expensive, whereas we would be able to get a lot of information and still be able to have some meaningful contribution to science doing the study in Sri Lanka. So those were the three to four major reasons for planning the study in Sri Lanka.
Thank you. So I think our time is up. So I would like to thank you again for being with us today. I would like to echo what Dr. Turan said in the chat, that this presentation was impressive. Your work is really impressive, with many implications, not only in Sri Lanka, but potentially in the United States and really globally. And it's really even more impressive that you were able to accomplish this work during this difficult year. So we would like to thank you, wish you good luck, and we are looking forward to your publications and results. Thank you so much for being with us, and thank you to the audience for being with us.
Thank you, everyone. Thanks for your
Thank you.
participation.
You're welcome.
Thank you so much.